Welcome to today's webinar from the Agency for Healthcare Research and Quality about AHRQ's CAHPS program, addressing emerging needs for patient experience measurement and improvement. My name is Joanne Sora. I'm a Vice President at Westat and the Project Director for the contract that supports AHRQ's CAHPS program, and I'll be the moderator for today's webinar. Next slide, please. First, let's briefly go over a few housekeeping items. If you're having any issues with sound coming from your computer audio, you can connect to the webinar audio using your phone by clicking on phone call to find the dial-in number and meeting ID, or call me to enter your phone number and receive a call back from Zoom. If your computer freezes during the presentations, you can try logging out and logging back in. At any point in today's webinar, you may ask a question through the Q&A feature. Look for the Q&A icon next to the Raise Hand tab. We encourage you to share your name and organization or role when you type your question, and then speakers will respond to your questions during the Q&A portion that will take place at the end. Please note that the Raise Hand feature and chat are also disabled. You can download presentation slides, view the agenda and speaker bios on our event website, https://events.westat.com/CAHPS. Finally, there is only one Zoom link for the entirety of today's webinar. If you leave at any time, you can rejoin with the same link provided in your email after you register. Next slide. Here's our agenda for today's webinar. We'll start with Dr. Karen Ginsberg giving an overview of AHRQ's CAHPS program. Then Ron Hayes will present information about improvements to the CAHPS survey instruments, followed by Susan Edgman-Levitan, who will discuss responses to current information needs of CAHPS users and using the CAHPS surveys to improve patient experience. We will end with a questions and answer session at the end. Next slide. Now I'm happy to introduce our speakers for today's webinar. We're pleased to welcome Karen Ginsberg, who directs AHRQ's Consumer Assessment of Healthcare Providers and Systems, or CAHPS program, as well as the Surveys on Patient Safety Culture, or SOPS program. I'm also pleased to introduce CAHPS Consortium members, Ron Hayes, representing the RAND Corporation's CAHPS research team, and Susan Edgman-Levitan, who represents the Yale CAHPS research team. I'm Joanne Sora, and I'll be moderating today's webinar. So let's begin, and I'll hand it off to Karen Ginsberg at AHRQ. Karen?
Thank you, Joanne, and welcome everyone. Can we have the next slide, please? Welcome everyone to this webcast on the AHRQ CAHPS program's new efforts to address emerging issues and stakeholder needs. AHRQ's CAHPS program is funded by cooperative agreements and support contracts, and collectively they're referred to as CAHPS 6, meaning this is the 6th iteration of program funding. I'll start today's presentation by describing the objectives AHRQ's laid out in its request for proposals for the cooperative agreements, now called the Notice of Funding Opportunity, or NOFO. And then you'll hear from cooperative agreement holders about their proposed strategy to address AHRQ priorities for the CAHPS program in a comprehensive 5-year research effort. And the next slide, please. AHRQ is a science-based agency investing in research and evidence to make healthcare safer and improve quality. We create tools for healthcare professionals to use to improve care for their patients, and our products are available to other organizations like CMS or NCQA to use for their programmatic purposes. Regarding the CAHPS program, here at AHRQ, we have advanced the science of patient experience by creating valid and reliable surveys that can be used to compare across entities, supplemental items, including narrative items, quality improvement tools, voluntary databases for selected surveys that are used for quality improvement, and conducting research to advance the science of patient experience, including best methods to administer CAHPS surveys and report CAHPS survey findings. On the next slide, please. AHRQ has supported the CAHPS program since 1995. The original goal of the CAHPS program was to address consumer needs for health quality information on health plans and to make sure that the consumer perspective is represented. They ask the questions: what do consumers want to know? What are the existing sources of information? And does the information represent the consumer perspective? The next slide, please. After 28 years, we continue to prioritize what consumers want to know and make sure that the CAHPS surveys reflect the patient experience and the voice of the patient. We continue to use the best methods in survey science to ensure that our products are current, responsive to users and the changing healthcare landscape, and focus on improving patient experience. The next slide, please. I want to emphasize the integral role of including the patient's voice in CAHPS survey development. The CAHPS program has always focused on what patients wanted CAHPS surveys to measure and report. Every survey development project begins with every survey development project uses a standardized process that begins with understanding the patient perspective. And how do we do this? We begin every development project by asking patients for their thoughts about good quality healthcare and what the CAHPS surveys should measure and report. And their responses form the domains of the resulting CAHPS surveys. Next slide, please. In 2022, AHRQ invited applicants to conduct research and related activities in 5 broad areas. And applicants had to address all 5 areas that were listed in the NOFO. We were open to topic area that the applicants wanted to pursue, but we listed areas of interest. Successful applicants had to demonstrate experience and ability to complete research, as well as collaborate, work in teams, and develop partnerships with other organizations. Next slide, please. I'm going to go through these different areas so you can see what we requested in the NOFO. The first area had 2 parts, survey and supplemental item set development, revision, and trademarking. So for survey and item set development, the applicants had to propose developing at least 1 survey or supplemental item set. And we said we'd be interested in the following, but again, it was their choice about what areas to pursue. So we listed inpatient mental health settings for survey, respectful care, issues of perceived bias, trust, patient safety, experience of care for the disabled, and experience of care in clinical trials. Next slide, please. That area also included a request, a point for surveyor and item set revision. Applicants had to propose at least 1 current existing CAHPS survey or item set that needed updating to remain current with users, and propose an approach that included stakeholders and patients in the process. We were open to topic area, but we specified we were interested in health plan, the CAHPS health plan and CAHPS clinician and group surveys. Next slide, please. In the second area, survey methods research aimed at achieving health equity. Again, propose 1 study of survey methods focused on health equity issues. Examples included the effectiveness of survey administration modes to facilitate participation by underserved patients or those who have limited means of participating in CAHPS surveys, including web-based surveys, or developing, administering, and analyzing and reporting measures of sexual orientation and gender identity, or the SOGI questions that can be used on CAHPS surveys. Next. Applicants had to propose at least 1 study that examines the analysis and reporting of patient narrative data, CAHPS patient narrative data. We were interested in furthering the analysis of patient narratives using natural language processing, reporting patient narrative data, or how to use them for consumer choice, quality improvement, and improving health equity. Next slide, please. Applicants had to propose at least 1 study of quality improvement using CAHPS data. And we had examples of how healthcare organizations use CAHPS data for pre and post measures of change, the clinical implications of improving patient experience and patient safety, the business case for improving patient experience, and exploring the relationship between patient experience and healthcare worker job satisfaction, workforce burnout, and workplace safety. Next slide, please. Finally, the 5th area, developing internal and external program communication strategies. The AHRQ program spends a lot of time on communicating to our users and communicating internally in the program as well. The applicants had to talk about how they were going to support disseminating and promoting activities of the CAHPS program, and also develop and support our annual CAHPS research meeting. And I invite you to join us. Our next research meeting is scheduled for October 19th. It's virtual, it's free, it's open to the public. It's going to be about patient experience, patient safety, and provider well-being, associations and paths for quality improvement. I'm going to read the registration link here for you. It's www.arc.gov/caps/news-and-events/research-meetings. So we invite you to join us and let us know if you have problems registering, and we hope to see you there. And thank you again for joining us. And with that, I'm going to turn this over to Ron Hayes.
Thank you, Karen. I'm going to touch on 4 areas today briefly. Number 1, I'm going to talk about our creation of the CAHPS Clinician and Group 4.0 beta survey. And then second, I'll talk about our plans for eliciting stakeholder input about the CAHPS health plan and clinician and group surveys. Third, I'll talk about evaluation of the use of the web as a mode of data collection for the CAHPS hospital survey. And then finally, fourth, I'll talk about the efforts we're making to assess a variant of the CAHPS clinician and group survey that has simplified item wording. Next slide. So first, in response to the increase in use of telehealth during the pandemic and changes in healthcare, the CAHPS team developed a 4.0 version of the clinician and group survey that focuses on the most recent visit and is relevant to in-person, phone, and video visits. Next slide, please. We released the beta survey 3 years ago in 2020. Since then, we've worked with UCLA to conduct a pilot test with about 400 patients, and we've collaborated with the VA to conduct cognitive interviews and 2 large field tests. We refined the survey based on each type of data collection, and we expect to finalize it next year. Next slide. Second, we will be getting input from patients, providers, and other stakeholders about the CAHPS 5.1 health plan and the 3.1 clinician and group surveys. We will be using the RAND online platform to obtain feedback about items to delete, revise, and add to these surveys. Round 1 ratings will be presented to stakeholders, and they will then provide round 2 ratings that will help us decide upon content for the next version of these surveys. Next slide, please. Third area I'm going to touch on is been led by Mark Elliott and others, including people at CMS, in which they evaluated the use of the web to collect CAHPS hospital survey data. Adding the web as a first stage, followed by mail and then phone, yielded the highest response rates, and in particular, improved survey completion by Black and Hispanic patients. For January 2025 discharges, CMS is planning to include web followed by mail, web followed by phone, and web followed by mail and then phone modes, in addition to mail only, phone only, and mail phone modes of data collection. Next slide. Fourth, we created a variant of the CG-CAHPS 3.1 mail survey that simplifies the wording of questions and presents one complete thought on each line. So shown here is an example of how one of the CAHPS Clinician and Group 3.1 item stems was modified to produce an easier to read question. The CAHPS item has several words written in the passive tense, and the line length determines wrapping to the next line. In contrast, the item at the bottom, the easy item, is short and presents a single thought on each line. As a result, the reading level was reduced from college to 3rd grade level. Next slide. We are finishing data collection from a sample of patients at a federally qualified health center that provides care primarily to Hispanics. We randomized adult patients to the CAHPS CG 3.1 survey, or the easy version, and we will compare response rates, item completeness, reliability, and correlations of the composites with the global rating of the provider. So that ends my brief presentation, and now I'd like to turn it over to Susan Edgman-Leventon to discuss some of the other things that we are doing to support the needs of CAHPS users. Thank you.
Thank you, Ron. Let's go to the next slide. So the first thing that I want to mention is that we have a very robust CAHPS communication team that has representatives from both the Yale and the RAND team, as well as AHRQ and Westat. And the goals of this group are to share information about our research activities with stakeholders and designated partners. And also, I think most importantly, to actively solicit and listen to stakeholders' feedback and concerns about planned and ongoing activities. And it also helps us improve our internal collaboration. We are gratified that there is tremendous interest in new and different ways to improve the patient's experience of care that also require different methods of capturing the patient's voice and the family's voice. And we are very interested in exploring these and learning more about them, and also sharing with people what we already know about many of these other qualitative methods. So we also, the communications team also shares information about the reliability, the validity, and lots of other issues that come up in what I sort of think of as the myths about the value of measuring the patient's experience of care. And I think that's also a very important role we play when we see articles or other things that may undercut the value of the patient's experience of care that we think need to be addressed. Next slide. So when we talk about what is the patient experience, what are the things that we are looking at? And this shows several of the domains or aspects of the patient's experience that various CAHPS surveys capture. I'm not going to read all of these, but I do want to underscore something that Dr. Ginsberg mentioned, and that is we really focus on measuring the experiences of care, the processes of care that patients and families tell us are most critical to them and to how they perceive overall quality of care. Next slide. And so what do we know about the relationship between patient experience outcome measures and other clinical and quality outcomes that people are very interested in? And this is often where a lot of the myths arise. So we know that, and there we can share, we have lots of articles and lots of bibliographies that we can share with people who are interested, but we know that non-adherence among physicians whose communication scores are low is substantially higher than physicians who participate in communication skills training and have better patient experience scores in that domain. The VA did a study with us a few years ago, looking at patients that were hospitalized for heart attacks and AMIs, where we found that controlling for comorbidity, clinical and demographic factors, their patient ratings were associated with the highest outcomes 1 year post-discharge. And we also know, for example, that with the health plan survey, health plans that are in the lowest 10% of the health plan survey that NCQA requires for accreditation have 4 times higher disenrollment rate than health plans that are in the top 10%. And these are just some examples of what we know about the relationship between patient experience measures and results and other clinical and business outcomes that are important. And this is really going to be the focus of our research meeting that Karen mentioned on October 19th. So let's go to the next slide, and I'd like to talk a little bit about the new work that we're doing in this round of funding. So one area that I am very excited about is that we have begun work to develop childbirth surveys for women and birthing people that will focus on inpatient experiences and labor and delivery and the prenatal and postpartum care. And we are hoping to design these for use in hospitals and birthing centers. And we put out a request for information in spring of 2023. Then we were very happy with the feedback that we got there. And we're also in the process of planning and coordinating a stakeholder expert panel where we're bringing together many people that we think will provide us with critical guidance about what matters most to people that are experiencing maternity care. What are the best ways to collect feedback from them? What are the sites of care that we want to evaluate, and any other issues that may arise? And so we did get responses from about 25 different organizations. Most of the responses to the RFI represented large national organizations, either professional organizations for people that provide maternity care, and for many of the national organizations that are really working on equity and other issues related to the crisis that we have in maternal morbidity and mortality. Let's go to the next slide. We also are working on improving and updating a mental health survey that has actually been available for many years. We've had a technical expert panel meeting in August, and that focused on the content, who should be sampled and who should be surveyed, and what facilities should be included. The timing and reference period, how long should we wait after somebody has had an experience with a mental health provider to be completed, and then which populations and what survey administration modes are going to work best in this setting. Let's go to the next slide. And then we also had a lot of discussion about the types of cognitive interviews we need to do, which we always know are critical to developing really high quality survey items, where we might want to conduct field tests, and then who are the populations of interest that would be included in any sort of mental health surveys. Let's go to the next slide. So I think that many people, when they think about the CAHPS Consortium, probably think that we're just a bunch of sort of survey geeks. And in reality, the thing that we are the most passionate about, and why we have devoted so much of our time and energy to this work, is that we all care deeply about creating patient and family-centered healthcare organizations and systems of care. So the improvement side of our work is really critical. And I think for many of us, it's what drives us to do this work. And so we think about how CAHPS surveys are used to improve experience. How is the data collected? How do we know that the data is reliable and valid? We're not just trying to develop surveys that make all of us feel good as a healthcare clinician or an organization. We really want to know that the data is accurate and that it's actionable. How does it identify the areas that we need to focus on for improvement? And then how do we employ targeted strategies that are evidence-based to the extent that we know that can help improve overall performance? Next slide. This is a picture of the CAHPS Ambulatory Care Improvement Guide. I know you can't read all the different components of the guide, but this is actually one of the most popular items on the AHRQ website. And the guide looks at everything from how patient experience scores are related to other clinical outcome measures, How do you think about your data analysis and how you organize the data and feed it back to people that need to see it and use it for improvement? We then talk about different strategies beyond surveys to capture the patient's voice that really help on the improvement side. And then we focus, I would say most of the guide really is designed to share interventions that we know can improve the different domains in most of our surveys. Right now, we're going through a really substantial update of the guide. Next slide. We've conducted lengthy interviews with 27 different people from 16 organizations that represent health plans, health systems, federal agencies, chief experience officers, and quality improvement experts in different types of healthcare organizations all over the country. And we're just beginning to focus on what the update will consist of, but we know that we need to update a lot of the evidence and the literature in the guide. We also are going to be adding a lot more information about improving care and reducing reducing disparities. And then we also hope to include new topic areas such as improvement strategies and interventions for mental health and for maternity care. Next slide. And so I also now want to focus on some of our quality improvement studies. And I really want to give credit to Denise Quigley, who leads the quality improvement work for RAND, and to Ingrid Nimhart and Karen Sapuka. And I'm also involved with the quality improvement studies for the Yale team. So RAND is conducting a study with 2 federally qualified health centers, really looking at and hoping to create a much deeper understanding of the impact of provider-patient language concordance with Spanish-speaking patients, and learning how the different ways of providing interpreter services affect the ambulatory care experience. They also are doing a study in partnership with a large freestanding children's hospital to examine the associations between quality improvements efforts to improve the patient's experience with patient experience measurement approaches, and then looking at that relationship to culture and employee burnout. Next slide. The Yale team, which is in my world, since I'm here at Harvard, what I fondly call the Yale Harvard team, is we have 2 improvement studies that I'm very excited about. The first one is with the Pentucket Medical Group, which is part of the Mass General Brigham Health System here in Boston, that we are working with 2 of their large practices, primary care and specialist. And we are using the new patient engagement items that are part of the clinician group CAHPS survey that were really designed to look at primarily with patient engagement for people with multiple chronic conditions. And so we'll be administering the surveys to patients that receive care in 2 medical groups in very diverse communities. And then we're going to be feeding the data back to the clinicians there, and then supporting them with doctor-patient communication strategies with a very strong emphasis on educational interventions that improve shared decision-making. And then our second study is looking at working with the Cleveland Clinic, and this is a study led by Ingrid Nimhart and Dale Schaller and our narrative item team, looking at how patients report about the emotional aspects of inpatient care and how this shows up in narrative items and how these can be used for improvement. And we know that, for example, and we already know that in that work that minority patients are 2.5 times as likely to report emotional distress in their cancer care than other patients, which is a very critical and important finding and very valuable for improvement. Let's go to the next slide. And so I also just want to share some of our work in narratives. So people may not be as familiar with all of the narrative work that's been led by Dr. Mark Schlesinger, Dr. Steve Martino from RAND, and Dale Schaller from the Yale team, looking at how we combine narrative comments with the survey data, which I think we have even stronger feelings about how important this is and critical to really effective quality improvement, because surveys tell us where we have a problem, but they don't tell us what the answer to the problems are and what the solutions might be. Patient narratives give us a lot of information that gives us more detail about the source of problems, as well as they often give us suggestions about how we can improve areas that have shown up as problematic in the survey data. And so this is just a slide from work that Dr. Nimhard has led, that actually just won awards at a large national management meeting. And we can share all of this later after the meeting. But let's go to the next slide, because I think that what we're finding is that sharing positive comments and actually sharing any comments back with our professional staff as well as our non-clinical staff, we actually think this may be one of the keys to helping prevent burnout. So if you could go to the next slide. So if you look at this, and this is based on another quality improvement study that was done with New York Presbyterian across many of their practices, both primary care and specialty practices in their ambulatory care network. So what we looked at is what happens, what is the relationship between burnout and clinical and non-clinical staff that see no comments, get no feedback from patients on a regular basis, people that see any type of comments, and then you see as you go down the red bars, people that see a positive mix have lower burnout, and then people that get the positive mix and get feedback about what are process problems that people have and what are communication and empathy problems and successes in the positive comments. Those clinical and non-clinical staff have the lowest measures of burnout, which is part of the Holy Grail that I think many of us that are working in various ambulatory settings and inpatient settings are very concerned about and really trying to find solutions for. So if you go to the next slide, I think we're at the question and answer period. So we're really looking forward to hearing from you about what kinds of questions or issues you'd like us to address. Thank you.
Thank you, Susan and Karen and Ron, for your really informative presentations. You've given us a lot of information, and I know we have a few questions that have already come in, but at this time, we're shifting to the Q&A session. And so as a reminder, you can ask a question through the Q&A feature, and we encourage you to share your name or organization or role when you type your question, and then we will begin the questions. And if you joined late, a replay of today's webinar will be made available on the AHRQ website. All right, so let's begin. We have a question here from Diane Kuhn from the Indiana University School of Medicine, who's an emergency physician. And this is a question, I think, for Ron. Are there plans to study mobile app feedback in addition to web platforms or evidence to support this?
Yeah, so I wasn't 100% sure of what that meant. Does that mean providing feedback to patients, to providers? Certainly, mobile phones can be used to answer questionnaires. So if there's some clarification on that, it would be helpful.
Okay, we'll wait for that. In the meantime, I wonder if, Ron, you can just address the web, and maybe we go back to that slide. I don't know about the web, the performance of web as a mode for responding.
Well, I can make a more general, because I went through that in some detail, but we do find the web as a very promising first step based on the HCAHPS results that Mark Elliott led. So we are exploring the use of web more generally, not by itself, but as a mixed mode administration. But I think there's a question from someone that asked about other possible ways to improve response rates. So one of the things that is in an article that I put in the Q&A is that the formatting of mail surveys can make a big difference. So there was a study done where use of color, good visual cues, use of a lot of white space and distinguishing questions, and in terms of navigating the questionnaire made a big difference in terms of response rates. So sometimes you'll get questionnaires that are very crammed together to try to save space, and that can lead to lower response rates. Also, one of the things that CMS is going to be doing is limiting the number of supplemental items for HCAHPS. So sometimes core surveys of CAHPS are really much longer because there's a lot of supplemental items that can reduce your response rate. Another small thing to note is that if you use phone only as a mode, often we recommend mixed mode if you want to maximize response rate, but phone only is good for younger and more diverse patients, while mail only actually works better with older non-Hispanic white patients. So it sort of depends on who you're going after, but that's why mixed mode is so important, because different types of people respond to different sorts of modes of data collection.
And Ron, can I just jump in for a second? Because I think that question may also have been asking about the use of SMS messaging, text messaging. And I think one of the things we've learned, and I've learned this firsthand because I led the work to improve the patient's experience of care at our healthcare system for about 13 years. And I think using text messaging to collect survey data, it may depend on your legal counsel at your health system, because some people interpret the rules about texting patients very strictly. And if a patient says, no, do not survey me again, if they get a survey through a text message, some systems interpret that as having to turn off all text communication with patients, and they don't want to do that. So they don't use the text functions that many vendors offer. Other health systems view those federal regulations a little more liberally and allow you to use text. So that's kind of an issue that I think we're all still sorting out.
Yeah, I agree. And there's a good commentary in the Journal of Patient Experience from 2021 that talks about, measurement of patient experience, catching up with the experience itself, where people are, texting and working with patient portals and so on. And they refer to like rideshare, where you get immediate surveys and how that can be valuable and so on. And we're always considering those possibilities. And we were very high on text, several years ago. And as Susan said, there's some difficulties that you can run into, unfortunately. Hopefully, that'll iron itself out over time.
Thanks, Ron and Susan. And Ron, you mentioned a couple of citations. One was Medical Care 2022, a systematic review about strategies to enhance response rates. And the other you just mentioned was Journal of Patient Experience from 2021. If anybody wants those specific citations, they can email us at caps1@westat.com. We'll be happy to send that on. All right, next question. This is from Janet Yetter. What is the timeline? And I guess this is for like Ron or Karen. What is the timeline for review and enhancements for the health plan surveys?
Okay, so Karen, I'll let you follow up because you're more sure about the ultimate timeline, but I just will say that RAND is leading the effort that I referred to, and we are intending to get the first feedback from our stakeholders later this year, very soon, and that will continue on to early next year. And then based on that, all the CAHPS people will get together with that and other information and start working on possible revisions. So it's a little hard to know exactly when, but I think we'll make a lot of progress by next year. But the ultimate completion of that is something that's up to what actually happens over that interim. But definitely in CAHPS 6, I know that's the intention, so I'll leave it at that.
I'll just add, it is hard to tell at this point, and and the reason why it's hard to tell is because we don't know what will happen through the course of research to update it. What kind of cognitive testing with patients the survey will need? Will it need pilot testing? Those kinds of things. And I think that this time of formative research, which has begun, will determine what's actually needed to produce a survey that is a CAHPS trademark survey and is a valid, reliable survey. But you can always, and you'll find out how to do this at the end of the webcast, sign up for our Gov Delivery listserv, and we will be posting whatever we need to post on the through our Gov Delivery messaging, and you know, you'll be apprised of when there are significant updates and we're ready to announce a new survey. If you have specific interests, email us and let us know. We're always looking for partners to test the survey, so let us know if you're interested in helping with that. And write to us through the CAHPS One email address.
All right, great. Thank you. The next question is a two-part question. They're both for Susan, and I'll break them up for you, Susan. So the first question from Anna Selenriek is, you mentioned the CAHPS improvement guide. Is there a similar improvement guide for inpatient hospital CAHPS?
There isn't a similar guide. There are many resources for improving HCAHPS, but initially, when the guide was first written, HCAHPS was not mandated. So the guide really focused on ambulatory. And I think it's a really important issue that I know we heard a lot about in the interviews that I just mentioned. And I think that's something we're going to have to consider when we think about updating the current guide.
Okay, there's another question. You talked about these interviews around the improvement guide, and Catherine Flanagan wanted to know how she can participate in those interviews. And Susan, what they can probably do is just email us at caps1@westat.com, and then we'll forward them to the improvement team, quality improvement team. But can you say just a little bit more about what would be involved in those interviews?
Well, the interviews, what we typically do in all the interviews that we've conducted to date, we asked the person that we were interviewing to actually review the guide and tell us what they liked, what they didn't like, what are interventions that we need to consider adding, what are interventions that we need to consider removing, anything that people thought would make it more user-friendly and more helpful to people that really want to improve patient experience scores. And I also just want to add that I think the improvement guide has a lot of information. It doesn't matter what patient experience survey you use. These interventions are effective, I think, for almost anything in that realm. And I also saw a question about the timeline. We are just synthesized all the feedback, and we actually are having a meeting coming up in the next few days to go over that and then decide how we're going to get started with the improvements. But one thing about the guide is that I think it's very rich and informative now, so don't wait for the update. It's there on the website, so please access it and use it. And I also think because of the way that it is formatted, we're probably going to be able, we don't have to wait till we have every single update ready. We can update different sections as we move through it, and then they will be on the CAHPS AHRQ website. Okay,
great. So the CAHPS improvement guide, just to reiterate, can be found on the CAHPS website at www.ahrq.gov/CAHPS under improving patient experience. And then if there's anyone who wants to participate in these interviews to provide some feedback about the improvement guide, again, just email us at caps1@westat.com.
Yeah, and we appreciate that feedback.
Next question, this is the second part from Anna Selenriak, is will the new maternity survey move away from the hospital CAHPS survey, which might mean, is it going to be a separate survey? And can you say a little bit more about how it might be related to the hospital CAHPS survey?
I think that's actually a really important question for our stakeholder expert panel. And I think that my hunch is that it's likely the inpatient survey is likely to build off of HCAHPS, but have new composites that are particular to childbirth care, labor and delivery, postpartum care in the hospital at least. But that is a question that's yet to be determined. And we are going to be working with our stakeholder expert panel and with our colleagues at CMS to figure out what is the best way to get this information from patients and make it available to the organizations that are providing their care. Because birthing centers, for example, don't conduct HCAHPS. And so we'll need to think about all of these issues as we move forward.
Great, thank you. Next question is for Ron. Are there plans to refresh the outdated language of clerks and receptionists and receive those results when these days results are just sent through portals?
The short answer is yes, and we've thought about this a lot, the clerks and receptionists and, alternatives with staff or some wording that isn't so dated. So yes, and we've already done some things that are relevant to that question in terms of the CAHPS 4.0 survey, in terms of trying to be more current with how test results are received. So that's already in process, and the stakeholder input will look at the same sort of issues and other issues, and we intend to revise as needed.
Thank you. The next question, I think I'm going to just respond to this, is BJ Dempsey, who asked if we could provide the research that supports the relationship between patient experience and outcomes, which was on slide 27. And so the reference for that can be found in the CAHPS Improvement Guide, which is again on the CAHPS website, but the citation is Materco from Health Services Research in 2010. And so if you'd like to email us again at caps1@westet.com, we'd be happy to provide that citation.
So I also put in a response that Rebecca Ann Hang Price has published a couple of papers a while back that are also relevant to that question.
And that's going to be the main focus of our research summit on October 19th.
So we can probably provide a couple of references actually on CAHPS research related to outcomes. And just going back to thanks for mentioning that, Susan. So if anyone wants to register for the October 19th virtual CAHPS research meeting, that's going to focus on patient experience, patient safety, and provider well-being, there's a link to the agenda and a registration link on the CAHPS website, the AHRQ website. All right.
Joanne, can I make another comment? I'm seeing lots of questions about the new updates for HCAHPS. And I know CMS has just released information about the updates, both in modes of administration, adding supplemental items, and the new items. And maybe there's a link we could put in the chat that we can share with people so they can see that, because that information has just recently come out from our colleagues at CMS.
Okay. Next question here, I believe might be for you, Karen, from Rachel Phoebus. I work in behavioral health quality improvement for a large national payer. I was wondering when the revision of the ECHO instrument, which according to the AHRQ website will be called the Mental Health Care Survey, will be finalized and released for use. We're finding that the ECHO 3.0 survey tool is outdated. It instructs respondents to skip half the questions if they receive their treatment via telehealth. And because telehealth is so prevalent, this is reducing our response rates on the survey. So Karen, any updates on when the new mental health care survey might be released?
Thank you for that question. It's a good question. We haven't quite finished the testing. We don't know if we're going to be able to finish the testing for several reasons. And we are thinking about releasing it anyway as a quality improvement tool without the field testing, although it will be cognitively tested and we'll share the results of what we've done. But we have to make some decisions about that. There's excellent research going into it, and we're just debating how we will release it. So again, connect with us on our GovDelivery listserv, and you'll see updates.
Okay, next question is for you, Karen, from Mary Kitayama. Are there plans to include other languages beyond English and Spanish, specifically Asian languages?
I think that depends on what survey you're referring to. All of the surveys that AHRQ produces and that have a CAHPS trademark are at least translated into Spanish. And then as they're adopted and used by other organizations or federal agencies such as CMS, they determine what other languages they might need these surveys in for their programmatic purposes. But that said, there's a lot of surveys. A lot of the surveys have been translated into in other languages. They are unofficial. We can't verify whether they still meet the requirements of a CAHPS survey, the testing requirements, and we know that folks are interested in these translations, even though they might be unofficial. So we're trying to figure out a way to provide a little more information about that to you. But for now, I would consult the CMS website for their required surveys for other translations of the surveys that they administer.
Yeah, and they are available in many different languages.
Great, thank you. Next question is for Ron. Can you say more about the testing of the CG CAHPS question stems? Would similar changes apply to the updated health plan CAHPS survey?
So this is just being evaluated, for the first time in a clinician and group. And so we don't really know the effect. And one of the concerns that might be there is that by simplifying it too much, you might lose some valuable information. So it's an open question, really, what we're going to find. But if we do find positive results, then I would think that we would naturally then start thinking about the possibility of similar approaches for other CAHPS surveys. You can't say specifically HCAHPS, but we'd at least want to consider using this, whatever we learn, for other surveys that are out there.
All right, next question is for you, Ron. Are there changes to the core survey questions that address sexual orientation and gender identity, or SOGI?
Yes, that's one of the major things that I believe it was in the NOFO as well, but we're definitely already in process to start testing alternatives to the questions we've used for years. So, for example, when we're working with the VA on CAHPS 4.0, they have been administering a version of a gender question that has about 6 response options. So it allows for transgender responses, non-binary, and other. And we don't know exactly what the right wording is yet, but we're basing it on the work that has been done to date. And we're also asking people, do they consider themselves to be different categories, heterosexual, gay, lesbian, and so on. So we're looking at different possibilities for SOGI questions and testing them, and that's going to be a big part of CAHPS 6.
Thank you. Susan,
Yes.
what innovative ways are health systems using CAHPS to improve patient experience?
Oh, goodness. I think there are many innovative ways organizations are using CAHPS surveys and all patient experience surveys. I think that using comments is incredibly valuable. both positive comments based on what I shared earlier about sharing positive comments with clinical and non-clinical staff, and that in its relationship to helping ease at least some of the burnout, helping identify solutions to problems. And I also think a very important way that many organizations are using comments is to identify safety issues, diagnostic error, failure to close referral loops, failure to get test results, critical test results back to patients. Those issues often show up in comments, which is very, very valuable. I think also partnering with patients to co-design and improve care is another way that people are using their CAHPS data and patient experience data with patient partners and families to help identify, you know, if we're seeing this problem in a survey, what are the things that we could do to improve care from your perspective, which personally I think is the absolute most critical way to design patient-centered improvements. Most of the things we do on our own don't hit the mark, and they're often the most expensive thing you could implement. And patients really help us simplify these interventions in a way that is valuable to us and also makes them more effective. Can I answer one other question that I saw in there? And that is about, are we planning to add questions on CAHPS about nursing? And I just want to mention that because that's been a big issue, especially for organizations that are going for magnet recognition. And one of the challenges that we have in the ambulatory setting is that patients actually don't know who a nurse is. And they often think that a receptionist, a medical assistant, or even a female doctor is a nurse. And so we've actually had lots of conversations with the Magnet Commission and other groups about how we can do a better job with that. Because most, at least I also do a lot of work in primary care, and the most frequent place that a patient is going to have an experience with the nurse is in the triage process. So that's something that I think we really need to look at, but we know it's an issue, but we worry a lot about just adding questions about nurses because we know that the person responding may or may not be talking about a nurse. So attribution is a big issue there.
Joanne, we're drawing to a close. Could I make a last comment?
Sure.
A couple of last comments.
Yeah.
First, you heard a lot about what the CAHPS 6 program is doing, but you didn't hear everything. We're actually doing a lot more. This is a very, very productive team. And I want to make sure that you're aware of some of the other things that we're doing, including developing items on perception of bias in ambulatory care settings. I don't think we talked about that. Ron's doing work on items targeted at patients with functional, visual, and hearing impairments. There's also work on the narrative side on assessing algorithmic bias and natural language processing. There's just a ton of stuff coming out, and we didn't hit on some of these other critical issues. So I invite you to look at our website and stay in touch with us to find out more. Always feel free to drop us a note if you want more information on something that we're doing. I also want to say that we didn't answer some questions that you had. We pay on your registration questions when you registered, or in the Q&A today that had to do specifically with programs that are administered by other agencies like CMS for HCAHPS, for example, or OAS CAHPS survey. And the best source of the information is to go back to CMS to find out. They set the requirements, and they're the ones that really should be advising you on changes to program requirements.
That's really important. Thank you, Karen, for adding those comments. And thank you, Susan and Ron, for your presentations today and for helping answer all of these questions. We can go to the next slide. We periodically send email announcements about just some of the updates that Karen was talking about through CAHPS email updates, which you can sign up for by going to the top right corner of the AHRQ website and choosing the email updates associated with CAHPS. Next slide. And if you have any further questions or comments, we didn't get to your question, or you want some of the citations that were referenced today, you can email us at caps1@westat.com or call us by phone at 1-800-492-9261. And much of this information is also available on the CAHPS website. There's a CAHPS bibliography, the CAHPS improvement guide, registration for the CAHPS research meeting available at www.ahrq.gov/CAHPS, CAHPS. Next slide. So a brief webcast evaluation will pop up when you close out from today's webcast. And please take a moment to provide us with feedback because it helps us improve our offerings for the future. So thank you again for joining us. And this concludes today's webcast.
Thank you for your passion for taking good care of all of our patients and their families. That's what we deeply care about. So thank you.